CDK4/6 inhibitors have really completely changed the way we treat patients with metastatic hormone receptor positive HER2 negative breast cancer, improving progression free survival, and certainly, as demonstrated in a number of trials, improving overall survival, including in pre and perimenopausal women in the first line Mona Lisa 7 trial, which also was updated at San Antonio. So I think that, we're sold on this. It seems to be a very important way of treating patients, but anytime we improve outcome in the metastatic setting, we want to move that into the early stage setting so we don't have patients recur. The challenge is that hormone receptor positive disease, 50% of the recurrences occur after 5 years. So the adjuvant trials all worked hard to try and identify a group of patients who would be at higher risk of recurrence in the first 5 years. Monarch-E was the most successful at doing that, and also certainly is the only positive trial. That trial randomized a large number of women who were high risk either by having stage 3 disease by 4 or more axillary lymph nodes, or if they had 1 to 3 positive axillary nodes, they had to have grade 3 disease or a tumor size of 5 centimeters or greater. A small number of patients were enrolled in a second cohort that had 1 to 3 positive nodes and had a centrally confirmed Ki-67 of 20% or greater and didn't fit into those other high-risk criteria. So one of the criticisms of Monarch-E on its initial presentation and publication was the short median follow-up. So only 12.5% of patients had completed 2 years, and the median follow-up was just a little over a year. At this analysis at San Antonio, the median follow-up is 19 months, and a quarter of the patients have completed the 2-year treatment period, and they continue to show an improvement in invasive disease-free survival, now with this longer, but still early follow-up, with an absolute difference of 3% in 2-year invasive disease-free survival. They looked at distant disease-free survival as well, and showed that the difference has been maintained, which is quite encouraging. The original design showed a 3%, the original presentation showed a 3% difference, and now with a little bit longer follow-up, it's still 3% favoring abemaciclib. The other new finding in this presentation was isolating out the patients in cohort 1 and 2 who had a Ki-67 of 20% or greater confirmed centrally. This was also further analyzed in a poster presentation at San Antonio. And what they showed was that there was a marked difference in 2-year IDFS in patients who had a high Ki-67 who received abemaciclib versus endocrine therapy alone, with a 4.5% absolute difference and a hazard ratio of 0.691, highly significant. And interestingly, the curves appear to be separating later, starting around the 9 to 12 month range and staying separate. And I think that's also really important. So that was very cool data. And then we saw the data from Penelope-B that looked at a very high-risk group of patients who had residual disease after neoadjuvant chemotherapy and randomized them to palbociclib or placebo for a year. Now, it was only a year of therapy, and it was placebo-controlled. Similar to Monarch, most patients completed their expected therapy, unlike the Palace trial, where almost 50% of patients who discontinued palbociclib. So most patients did not finish 2 years of therapy. But it's a high-risk population. And what they showed was that over time, the curves actually started out separated. So if you looked at 1 and 2 years, the curves are separated. But remember, when you've gone past 2 years, you last saw that CDK4/6 inhibitor a long time ago. And the curves then came together with absolutely no difference in progression-free survival. The Palace trial also showed no difference in PFS, but they had a fair number of patients who had a relatively low risk of relapsing in the first 2 to 3 years. So we end up with an exciting positive trial with an enhanced efficacy in patients who have high Ki-67 and a new understanding of which patients may be at risk for early recurrence where we may be able to change outcome. What we need is longer follow-up on Monarch-E. We need to know whether or not this effect persists over time or whether or not we're simply delaying recurrence. And of course, we're going to see that over the next couple of years, but it's still a very exciting advance for our patients who have the worst prognosis, hormone receptor positive breast cancer.